that we've got about 80 of our closest friends that have already jumped on, maybe more. And we are so excited to welcome you today. So my name is Idisha Bellamy. I am the Chief Operating Officer here at Maryhurst. And before we get started, I'm going to go through a few easy housekeeping items just to make sure that we have the best impact as it relates to our conversation today. So to get started, due to the high number of attendees, please be sure to mute yourself for the duration of the call. That's rule number one, pretty easy. In addition to that, we would like for you, particularly if you are not a Maryhurst employee, to place your name and organization in the chat. If you are unsure about the chat, that function should be at the bottom of your toolbar. So please, at this time, we'd like to give you a second. Type in your name and the organization in the chat. Welcome, MSD, Key Assets, hello. Who else is with us? Wonderful, I see the library, great. St. Joseph Children's Home, welcome. As you all are doing that and getting familiar with that chat function, we ask you to use that if you have questions for any of our speakers today. So we do have a moderator that is monitoring the chat space. Please be sure if you have a question, rather than unmuting, to just go forward with typing your question in the chat, and we will do the best that we can to get to as many questions as we possibly can today. Lastly, last housekeeping item, please be on the lookout for a post-event survey. This will go out to each attendee. This will be an opportunity for you to give us feedback on today's event, and we appreciate that feedback. All right, just getting started. On behalf of our CEO, Paula Garner, our board, our staff members, and the families and children that we serve, I'm pleased to welcome you to today's event. Maryhurst is a trauma-informed agency committed to diversity, equity, and inclusion, and we serve children and families in this community in greatest need. Today's event is the final chapter of a three-part educational series about COVID-19 and the vaccine. We want to welcome all of our community partners who have joined for today's event from various agencies in the community, and we hope that you feel right at home today, and we look forward to what you'll add to today's discussion. Our first speaker for today is Dr. David Tom Cooke. In looking at his bio and his accomplishments, I pretty quickly coined him as what I like to call a slasher. Not because of the work that he does in the medical field, but because his titles are truly outstanding, and they include Associate Professor at UC Davis / Section Head of General Thoracic Surgery / Associate Director of Cardiothoracic Robotic Surgery / Vice Chair for Faculty Development and Wellness for the Department of Surgery. So as you can see, there are a lot of slashes there, and we are thrilled to have him joining us today. One thing that I have learned pretty quickly is that Dr. Cooke is someone who's truly gracious and willing to share his knowledge and time. And so I'm thrilled to welcome him and hand things off to our CEO, Paula, who'll get us started.
Right, good afternoon. And for Dr. Cooke, I think it's still technically morning, joining us from California. So we are, as Idisha said, we are thrilled to have you here. We're thrilled to have everybody participating, and Dr. Cooke and T Gonzales. And this is really a time where we want to be able to come together and learn and gain some education on such a critical topic for us right now. So Dr. Cooke agreed to do this for us, and I think this is a part of who he is, the way what I've gotten to know of him, in terms of sharing his learnings and sharing his passion for wellness for all people. So what we would like to do is I'm going to ask that Dr. Cooke share just a little bit of his story, part of which involves his participation in the Pfizer vaccine trial. And then we will take the rest of our time with him to do question and answer. We have had some pre-posed questions that people sent in, as you all, many of you did when you registered, and we appreciate that. We will also have an opportunity for questions in the chat box. But I think, you know, hearing from Dr. Cooke just before this, he really wants to make sure we have plenty of time to answer questions. So I'm going to go ahead and turn it over to you, Dr. Cooke.
Well, great. Well, thank you, Paula, and thank you, Idisha, for inviting me out here today. I really appreciate the opportunity to speak to everyone in Louisville. Actually, I have I'm a thoracic surgeon, and I have surgical colleagues at the University of Louisville. So it's always good to have that national connection. Idisha reached out to me because I've sort of spoken quite a bit about my experience with the COVID-19 vaccine and in regards to University of California, Davis, where I am, as well as the state of California and the different communities within California who've had questions about the vaccine and the vaccine process and whether they or their family members or loved ones should get the vaccine. And I actually was a volunteer for the Pfizer vaccine clinical trial, which means I actually participated in the trial. That was a randomized clinical trial. So back in August, I either received the placebo or the vaccine itself. And at the time, I didn't know what I was getting. And the people who were administering me the shot didn't know what I was getting either. And my response to the shot and whether I contracted COVID or not, and I'm a frontline worker, I come to work every day in the hospital, caring for patients, and some of whom have COVID, and that provided valuable data for the study. The results of the trial were extremely favorable, and Pfizer applied for what's called emergency use authorization to administer the vaccine. And after that, they were awarded, I was unblinded. So I found out that I actually did receive the vaccine itself, and that I was protected by the vaccine. So the one question I'm asked a lot is, why did I volunteer for the trial? And as what my mom actually told me, why did you be a guinea pig for this study, so to speak? And what motivated me to volunteer was the actual preliminary data for the Mrna vaccine that came out in the New England Journal of Medicine. And what I saw in that study that was published in New England Journal of Medicine, it was what's called a phase 1 trial. So a phase 1 means what they're doing is they're testing the response to the vaccine in regards to dose, and trying to find out what dose is safe and what dose is effective. And it's a smaller type study. The study that I participated was a phase 3, which was a larger study. And what I realized that in that phase 1 trial by Mrna, there was only one African-American in that study and very few people of color. What they found was that the vaccine itself was very safe and very few really bad adverse reactions in that phase 1 trial. But there was only one African-American participant. And I knew, we all know that the COVID-19 pandemic affects all of us, but we're finding that it's disproportionately affecting our communities of color, specifically in regards to mortality and death. And I knew that in order to understand whether this vaccine would be beneficial to communities of color, they needed more volunteers to participate in these trials. So when the opportunity to participate in phase 3 came about, I knew that in order to talk, I needed to walk the walk. And so that's why I volunteered. In addition, the phase 3 Pfizer study was being, one of the sites was at my own institution at UC Davis. So, and I knew the individuals who were running that trial, and I worked with those individuals every day in the clinical setting. And I understand their commitment to safe evidence-based medicine, their commitment to clinical trial research, and I know their ethical compass their moral compass, and their dedication to our communities at UC Davis, and many of whom are underserved communities. So I knew if they were running the trial, it was a safe, equitable trial. And that's what it proved to be. And so that's why I felt the desire to volunteer as a participant. And so a lot of my patients say to me, when I tell them about the opportunity to get a vaccine, they say, well, I don't want to be a guinea pig. And my response to them is, you're not a guinea pig, because myself and others who volunteer to be participants in the trial already served as the guinea pigs. We found out that it's a safe and effective vaccine, and therefore you don't have to worry about being a guinea pig, and you could benefit from the effects of the vaccine. Right now, there are 2 vaccines available in the United States. There's the Pfizer vaccine and the Mrna vaccine. Both are what are called mRNA vaccines, and it's an old technology that's being used in new, really exciting ways. And what that is you're not being injected with the virus. You're being injected with some genetic material. That genetic material does not become permanently incorporated into your DNA. Instead, that genetic material is used as a blueprint for your body to print out proteins. And those proteins are the spike protein that exists on the surface of the COVID-19. So when you see the different illustrations and pictures and graphics of the COVID-19 virus, those little pointy things on the surface of the virus is what's being printed by your body. And then your body's immune system then identifies that new printed protein and then develops a protective immune response. So therefore, if you get exposed to the real virus, then your body's able to fight that virus off. So when people talk about the Pfizer or the Mrna vaccine, they're pretty interchangeable. And then what's also interesting is that they have about a 95% effectiveness. So that means that you have a 95% chance to not have severe illness or mortality from COVID-19. And the way that the trial was designed, they didn't test me every day for COVID-19. They just asked me to fill out a log, and if I got symptoms, then they would test me. So because they didn't test me every day, they can't say that the vaccine protected me from catching COVID. They could just say that I didn't experience severe symptoms from COVID. So that's a kind of an interesting twist, and it shows that they can only report what they're designed to report. However, based on what we know about vaccines and the immune system, most likely the vaccine protects us from catching COVID-19, but the way it was designed, it can't say that through 100% certainty, but they knew, but that's what we suspect based on our knowledge of vaccines and the immune system. What's also interesting about, and I'm going to talk specifically about the Pfizer vaccine, and the Mrna vaccine is very similar, but the data I'm going to talk about is the Pfizer vaccine. There was about 40,000 participants in that clinical trial. Roughly 20,000 received the placebo, and 20,000, so saltwater, 20,000 received the actual vaccine itself. Of the participants in the trial, 10% were African American. So that sounds like a small number, but for enrollment in clinical trials, it's actually a large number because Black and African Americans are underrepresented in the clinical trials. So about 4,000 African Americans participated in the trial. And what's also exciting, about 25% of participants were Hispanic or Latino. So that's also an incredibly large number of individuals. So 25% of the participants were Hispanic or Latino. When we looked at actual symptoms, the most common symptoms for the vaccine were fever, fatigue, pain at the injection site, and nausea. Those are the most common symptoms. They did identify what were called severe symptoms. So those were elevated fever, but that's how they labeled the symptoms. When you talk about actual interaction with a healthcare system, so being admitted to the hospital because of the vaccine, or even lost time for work, those situations were extremely rare. So even though there were severe symptoms, people's interaction with the healthcare system were minimal. So that means they were able to go on with their daily activities. My symptoms were, I did not have fever, which although was the most common symptom, but I did have headache and I did have nausea and fatigue. But despite that, I still came to work every day. So I was able to continue my activities. Now, I'm not saying people should power through it, but that just gives you a sort of a frame of reference about how much it affected my ability to go about my activities of daily living. When you look at the actual data, and all this data is available online, if you go to the FDA's website and you look at the emergency use authorization for both Pfizer, application for both Pfizer and Moderna, you'll get this data. If you looked at the symptomatology was actually equal across all demographics. So whether you're male or female, Black or white or Latino, the symptomatology was actually equal across all demographics. If you do a little bit deeper dive, there actually older folks may have had less symptoms than younger folks. And then when you actually looked at the folks who got the actual vaccine and what percentage of those folks got COVID-19, it was very small, obviously less than 5%. But interesting enough, if you looked at the 2,000 African Americans who got the vaccine, so remember, 4,000 African Americans, or 10%, participated in the trial. Half of those received placebo, half of those received the vaccine. I was one of the folks who received the vaccine. 0 of those African Americans who got the vaccine actually got COVID-19. So that shows you that this vaccine was proved to be beneficial, and it proved to be beneficial across demographics. And that's why it was important to participate, and that's really relevant data. So I'm more than happy to answer any questions the group may have. And again, thank you for inviting me to be here today.
All right. Thank you, Dr. Cooke. And thank you for that, your story. Thank you for, as you said, walking the talk, and, the idea that you would go out before many of your patients so that you could come back and say, okay, I did this for you. And that, that's a true act of service. And so thank you for that. And for the very good explanation. You've actually answered a couple already of our pre-posed questions with the intro. So that's fantastic. One of the questions just that I think lingers for sometimes for folks, and it's good to just probably go ahead and answer it, is, can the vaccine cause the virus? So if you, well, can it cause a virus? The follow-up to that question is, if you've had COVID, do you still need to get the vaccine?
Yeah, so the vaccine none of the vaccines that are available or will be coming down the pike. So Johnson & Johnson, AstraZeneca, Novavax, there are going to be about 5 vaccines total. None of them can cause COVID-19. So for instance, the Moderna and Pfizer vaccines, those are just genetic material, mRNA. The Johnson & Johnson and the AstraZeneca vaccines are DNA that are delivered to you by a unrelated virus that cannot cause infection. It's just using the ability of this special virus to provide that DNA to your body to turn into an immune response. And then the Novavax vaccine is taking the spike protein as part of nanoparticles surrounded by an immune booster molecule. And so because of that, none of the vaccines can cause coronavirus, COVID-19. In regards to your second question, it's a very good question. And we don't really know the answer to, but because we don't know the answer to, and to make things simple in regards to vaccine rollout, if you are part of what's called tier 1 or tier 2, whatever your local local public health county recommendations. And in Louisville, it's you can look at that up at louisvillekentucky.gov on their COVID-19 resource site. If you fall into tier 1, which is right now it's frontline workers such as yourselves, healthcare workers, or tier 1B, which are going to be age categories, regardless if you had COVID-19 or not, then you should get the vaccine. And that just makes things simpler and easy to roll out.
Okay, thank you. That's very helpful. And we can also provide any of that information in terms of where you can go for our government website too, so that folks have that in case folks do not have that. But moving on to our next question. Do you anticipate that we will need to get the COVID vaccine every year like the flu vaccine? So I think it gets to the question of how long does it last and when do you need boosters?
Yeah, so the preliminary data shows that many of these vaccines promote what are called robust antibody response. So antibodies are the proteins secreted by your immune cells to help fight infection. And we figure that this may provide a lasting immune protection. However, we are seeing, you probably heard on the news about these mutant variants. And some of the vaccines show pretty good response to these mutant variants, so Pfizer and Mrna, although less so than to the original COVID-19. And then some of the other vaccines may have even less response to these mutant variants. So mutant variants actually are not uncommon for coronavirus because, as you can imagine, since we have this huge infection rate, and each individual person responds to the virus differently, and that could cause mutations. So we may have to have a situation where we have booster shots down the road. These companies are actually working around the clock on responding to the mutant variants and the mutant proteins. So, but the recommendation is get the vaccine now if you can. And then down the road, we may require booster shots as we integrate back into regular society.
Okay, great. Thank you. So our next question is there any projection, and it's a good segue from what you just said, is there any projection around when enough people will be vaccinated that we might be able to relax some of the safety precautions like masking or social distancing? I know that's a crystal ball question, but just your educated guess on that.
So right now, about 10% of the US population has received at least one shot. Anthony Fauci and others estimate that we need about 70% of the population to have been vaccinated to achieve what's called herd immunity. So herd immunity means that a certain number of the population has actually had the virus, so therefore have mounted their own natural antibody and immune system response. And then a certain amount of folks who haven't had the virus have been vaccinated. And so therefore, that number needs to amount to about 70%. So if you have random individuals who are not being vaccinated for whatever reason, they are protected by their surrounding community, and therefore we have what's called herd immunity. The problem is that we have what's called vaccine hesitancy. And that is thought to be about 30 to 40%. But the good news is that vaccine hesitancy is dropping because of programs such as yours, which are educating the community. Now, vaccine hesitancy is oftentimes higher. So when I mean vaccine hesitancy, I'm not talking about vaccine hesitancy for things like the flu or chicken pox or the mumps, but specifically COVID-19 vaccine hesitancy. That's higher than overall vaccine hesitancy. But we're seeing COVID-19 vaccine hesitancy higher in certain groups. And those groups include our Black African-American communities. And that COVID-19 vaccine hesitancy is in similar vein to overall mistrust or distrust of healthcare in our Black and African American and other communities of color. And that distrust is actually warranted based on historic, basically crimes against those communities, whether it's the Tuskegee syphilis experiment that occurred from the 1940s to the early 70s. If individuals are not aware of that study, Black males who were diagnosed with syphilis were never told that they had syphilis, even though penicillin was available at that time, which could treat it. And the natural progression of syphilis was observed in that population. That trial started in the late 40s and ended in the 1970s when it was a whistleblower revealed that study. And the CDC, the AMA, and even the National Medical Association, which is a Black organization, was aware of that study as it was going on. So that has created a sort of a cultural DNA of mistrust within our communities. Another example is the story of Henrietta Lacks, who was a woman with African-American woman with cervical cancer in Baltimore, was treated at Johns Hopkins. Her cervical tumor was removed, but without her permission, it was turned into an immortalized cell line, which really led to cures of many diseases and treatments, but also led to a billion-dollar industry, which she and her family were not able to benefit from until most recently. And a small fraction of the billion-dollar industry that generated from that. So those historical events, as well as structural racism that exists in healthcare today, has deservedly led many Black and African Americans to be mistrustful of the healthcare community. However, it is not the responsibility of those communities to develop trust. It is responsible of our healthcare community, healthcare industry to earn that trust from those communities. And that's why individuals such as myself and others who have sort of an inside baseball understanding of the COVID-19 vaccines and their trials are talking to alleviate some of those fears within our communities. And to be honest, my own family was not going to get the vaccine until I participated in the trial and talked about my experiences. There have been nurses and other frontline workers at UC Davis Medical Center who have come up to me and said, I wasn't going to get the vaccine, but now after hearing you talk about it, they have received the vaccine, and we have about 90% vaccine rate in our workers at UC Davis. And that's not just doctors and nurses, that's everyone, right? Because as I tell folks, doctors and nurses figuratively keep the lights on of our hospital, but there are individuals who literally keep the lights on in our hospitals, and that's our custodial staff. Who keeps our rooms, our patients' rooms clean and safe, who fixes things when things break down, who serves as security for our hospital, keeping our patients and our staff safe. Those individuals are getting vaccinated as well. So 90% of our workers, period, at UC Davis Health have been vaccinated. And that's been because of education and really addressing people's fears and not ignoring those fears.
All right, thank you, Dr. Cooke. And I think it is important, and I thank you for taking the time to walk us through that and explain a little further on vaccine hesitancy. And I think that's a huge piece of this puzzle. And I appreciate, again, healthcare professionals like you who are stepping out and helping to cultivate that trust. So thank you. We have a few other questions that had come into us prior to, and then we may have time for a few from the chat box as well. So one of these questions is around, it's actually related to the Johnson & Johnson vaccine and looking at that vaccine being different, and that there's different data So according to the person asking questions, it's 66% effective, but they are understanding that they may be assessing that vaccine differently. So what are the noticeable differences between what is right now the 3 vaccines, if you include Johnson & Johnson, and how is there a reason a person needs to decide which one is best for them?
Sure. So all the vaccines that are going to be available in the United States, except for one, are 2-shot vaccines. So you get 1 shot, then about 21 to 28 days later, based on the specific vaccine, you get a second booster shot. And that second booster shot is sort of designed to really boost the immune system. The Johnson & Johnson vaccine is a single shot vaccine. There's a lot of advantages to that vaccine. It's a single shot vaccine. It is DNA based. So they, as I mentioned before, they take another type of harmless virus to administer DNA to your body. DNA is a little bit more sturdy, so it doesn't require the deep cold storage that the Moderna and Pfizer vaccines require. Because it's single shot and it doesn't require deep cold storage, it's almost as easy to administer as the flu shot, right? And because of that, we can see that vaccine might be beneficial to our rural communities where they don't have that sort of deep freeze capabilities. And it might be difficult to get someone the first shot and then bring them back to get the second shot. We're also excited because as you know from the flu vaccine, I'm a surgeon, so I bring people into the hospital for surgery, and then we might do opportunistic vaccination for flu. So while you're here, let's give you the flu vaccine, and so you're protected. We can't do that with the Pfizer and Moderna vaccines because it takes a lot to thaw it out and get it ready. And then when we give you the shot, we have to be able to follow up with you to give you the second shot. But now with the single dose Johnson & Johnson, we could do opportunistic vaccination. So someone's in a car accident, they're in a hospital for a couple of days. While you're here, let's give you the vaccine. And then we don't have to give you the second shot. It is a little bit less effective than the Moderna and Pfizer. So actually the effectiveness of this vaccine in the United States is about 70+%. When they compared it, when they looked at the trial performed in South Africa, they found that it was only about 50+% effective for the new South African strain. And so when you combine that data together, that's where they got that 60+% effectiveness. So actually, it's actually 70+% effective. So then compare that to the flu vaccine. The flu vaccine is only about 40 to 60% effective in a given year. So when we're comparing it to sort of the magic of Pfizer and Moderna, which is 95% effective, it seems like it's less effective. When you compare it to vaccines in general, it's actually very effective. So I wouldn't get hung up about which vaccine I'm getting. I would just get a COVID-19 vaccine shot, and it will most likely be extremely protective for you in your situation.
Okay, all right, thank you for that. So just a follow-up question to that is, when we say effective, and you spoke on this a little bit earlier, it will prevent serious symptoms, and as we understand it, probably hospitalization. But could you further describe what would be considered serious symptoms that would be mitigated by the vaccine?
So serious symptoms really fundamentally means you have to encounter a healthcare system because of your symptoms, right? You have to come to the ER, you have to be admitted, you have to be on a ventilator, or you die. Those are sort of that spectrum of serious symptoms. Because, you know, most people who get COVID-19 don't die, and most people who get COVID-19 have, moderate level symptoms. The trouble is the lethality of COVID-19 is so much more higher than what we've encountered in the past for coronaviruses. As we see, as many of us, it's hard to find someone who doesn't know someone who hasn't died from this terrible virus, unfortunately, at this state. So, but again, the way these trials were designed, they just could not test people once a week for COVID-19. So what they did is they had people do a symptom log. And then when their symptoms hit a certain threshold, then they were tested. But the reality is, so that's why they can say it only protects you from severe symptoms. The reality is, based on our understanding of the immune system and the way vaccines work, most likely it's protecting us from catching COVID-19.
Okay, thank you. That was very helpful. The next question is that it has been reported that while the vaccine does not protect a person from infection only, so it can protect from the worst symptoms, that a person can still transmit the virus to others. Can you explain this? Does this mean that recipients are protected from the symptoms such as lung destruction, prolonged loss of taste and smell, that kind of thing? Basically, with this, I guess it's a follow-up to that question of, do you know if any of those prolonged effects if the vaccine can protect from those?
Yeah, so I think, so sort of two-prong approach was probably fundamentally, if I get vaccinated, do I still have to wear PPE, right? Do I still have to wear a mask and social distance? And then, if you get symptoms, will you get some of that function back? So the answer, so if a vaccine is 95% effective, that means it's 5% not effective, right? So you might catch COVID-19. So you need to wear a mask and properly social distance. The CDC has just released guidance that if you get the vaccine, you no longer need to quarantine if you have an exposure per se. So that really helps our ability to move around. The other thing is, as I mentioned before, we weren't swabbed every week. So in theory, we could be asymptomatic infected and not know it. And so that's why you still need to wear a mask and social distance until we've reached that herd immunity. And you'll see when we reach herd immunity, our numbers are dropping actually, which is good. And you'll continue to see that drop in numbers, and you'll see it flatten out, just like the flu in previous years. And then in regards to if you catch COVID-19 and you get those symptoms, whether you have the vaccine or not, will you?
I think it was just as would the vaccine help with, like, in terms of serious symptoms? Are they things like the long-term lung damage, that kind of thing?
So if it prevents you from getting the serious symptoms, then yes. It's unusual to get long-term lung damage if you haven't had sort of the serious lung symptoms. If you do get those serious lung symptoms where it requires supplemental oxygen or even intubation, then you may run the risk of long-term lung damage. And then other things such as other sequelae like taste and smell. If you lose taste and smell, most people have gotten that back, but some people have not. So those are things to watch out for. But those specific questions, I would encourage all of you to talk to your primary care provider, who could then do a deep dive with that data with you.
Great, thank you. Now we have time for just a couple, I think, of the chat box questions. One of the questions, which based on the work that we do at Maryhurst and some of our other partners that are participating today, is around what do trials look like for children? And do we have any idea of how long it might take for it to be approved for use in children?
Yes. So the answer is we don't know when this will be approved for children. They are opening up these clinical trials to age groups, I believe, as young as 12. We do have some data, but very minimal data for age 16 and up. but all that preliminary data looks okay, but again, is not a lot of numbers. But they have opened up the trials to younger folks. In regards to, so just to kind of continue that, maybe with pregnancy, should you get the vaccine if you're pregnant? So the answer is these trials were not designed to study vaccine approach in pregnancy. We do know that pregnant women get the flu vaccine all the time with very minimal problems with that. So the current recommendation is that it's up to the woman to decide if they want to get this vaccine while they are pregnant, because we do know from previous types of vaccines that has been relatively safe. We do have data from individuals who became pregnant during these trials. And I believe Dr. Anthony Fauci had talked about some of that data. It may be up to 1,000 women who were pregnant at the time of getting either dose of the vaccine. And all of those women have done well. And there have been no red flags in those women. So the recommendation is it's really, we encourage women who are pregnant to talk to their primary care provider to get that information. And it's really a decision for them to make.
Okay, great, thank you. We've one more question and then I'll wrap up. And we, just around whether or not, if you're vaccinated, could you still be a carrier of COVID-19? So example, you don't have symptoms. You've been vaccinated, you do not have symptoms, but could you still carry and give it to somebody else that you come into contact with?
We have to assume that the answer is yes. We have to assume that, and therefore we need to continue with the masking and social distancing. But that shouldn't be a nihilistic approach where you say, oh, well, then that's the case, I shouldn't get vaccinated. Get vaccinated once it becomes available to you. Obviously, there are supply issues with the vaccine, but we're up to about 1.5 million people vaccinated a day in this country, and 10% have received the first dose. But you'll still have to continue that social distancing and masking. And, you know, another quick sort of aside in regards to information, right? What we found is that you most likely need to stay away from social media in regards to getting specific information about the vaccine. I really encourage all of you either to talk to your primary care provider or to go to trusted websites. So the CDC has been really revamped and updated in regards to their information on their website. The FDA, if you want to learn more about the emergency use authorizations for these vaccines, and then your local state and county websites can be trusted in regards to information there as well.
Okay, fantastic. Thank you. Again, thank you so much for your time with us and just taking time from your medical practice to be with us today and educate us on this very important topic. Just really appreciate the work that you are doing and just the way that you have sought to positively impact wellness for all of us, but especially for underserved populations and those who may have vaccine hesitancy. So again, thank you so much. And we greatly appreciate your time, Dr. Cooke.
Well, thank you, Paula. Thank you, Adisha. Thank you, Maryhurst. I really appreciate you inviting me here. I really like this Southern hospitality and seeing over 115 souls online. It's really, I see a light at the end of the tunnel for this pandemic. I know it's really been tough on everybody. And I know for an organization such as yours is really on the front line in helping people and helping our community, especially our kids. It's really the rollout of these vaccines. Nothing is rolled out without bumps in the road, but those bumps are becoming smoother, and that allows us to see a light at the end of the tunnel, so we could get back into our daily lives and our family and our friends and our other loved ones.
Thank you. Thank you. And knowing that now that you have work associates in Louisville, when we're at a point, we'd love to have you come out and visit us in person. So thank you so much.
Well, I always love to get some good barbecue. So let me know.
We can make that happen.
Okay, great. Well, thank you very much, and have a good weekend and stay safe.
Thank you.
Thanks, Dr. Cooke.
Okay, bye-bye.
All right, we're going to go ahead and shift to the next portion of our forum, and I'm going to turn it back over to Adisha.
Thank you, Paula. I just have to say that was really awesome. And so I am excited about what I've learned in his kind words and really just energized by that, and excited about the next portion of our conversation with T Gonzales. I see T there. Hello. So excited to welcome T. T serves the residents of Louisville as director for the Center for Health Equity. T started with the center in 2010 through coordinating the department's Racial Healing and Equity Initiative. T's current work supports the department's strategy to deepen its focus on the root causes of health through authentic community engagement, strategic partnership, addressing data gaps and challenges, and through policy analysis and development. T is an active member of our community and is committed to contributing through numerous organizations, projects, boards, and community campaigns. Champion of equity initiatives, we are honored to welcome T to our forum today to lead us in real conversation about the state of health equity in our community and how COVID has affected us. And I do have some questions, T, but before we just jump in on the Q&A, what are your thoughts coming off of that last segment and hearing from Dr. Cooke?
Well, is it really great to hear personal perspective from somebody who's participated in the trials. There's, we're going to talk a little bit here about equity concerns related to vaccine eligibility and vaccine distribution within our community. And from a local public health department perspective, we really are, we see ourselves in public health as really a web, a network. There's no way for one department. We have around 250 stellar, cannot say enough good things about our local public health department staff, but there are, 250 of us, and they have been working so hard this past year. But the challenge before our community and communities across the world really means that we have to rely on a lot of partnerships, not just in healthcare, but through organizations like Maryhurst, who are using your platform in order to get out information this past year about COVID-19 and what's happening. And now, as we're moving more towards opportunity for vaccination, we're relying on everybody who has trusted relationships in the community to spread that message. So it was, great to hear from Dr. Cooke about his perspective, and then be able to be here with you all and share a little bit more about what equity has to do with vaccination. So appreciate the opportunity to be with you all today.
That's awesome. I think one thing that is so critical is not separating that equity from the pandemic sort of piece. And I'm very interested to hear from you about where those two things come together. I know as we were pulling this conversation together, they seem to sort of naturally, the pandemic and the equity issues just sort of fold in together. From your experience, can you talk about where you see the alignment in those two conversations?
Yeah, I'd love to. I'm going to pull up some slides here and be able to present with you all. Yeah, so I want to talk a little bit about, what do COVID-19 and the vaccine and then and health equity broadly have anything to do with each other. And it turns out they have everything to do with each other. So again, appreciating the opportunity to be here with you all. I want to say that I work at the Center for Health Equity, the director there, and that is a part of your Louisville Metro Department of Public Health and Wellness. We are a part of those of you who live here in Louisville, Jefferson County, we're part of your local government. And even for those of you who maybe you commute into Louisville, Jefferson County to do work, we are charged with ensuring that the conditions that health happens in, we're concerned with those. And so we see you as part of what our mission is every day, is to achieve health equity and improve the health and well-being of all of our Louisville residents and visitors. And so that would include those of you who are commuting to work every day. We're concerned with making sure that we can have a Louisville where everyone in every community thrives. And obviously in this past year, that has been a challenge. Would be a serious understatement to say the challenge that we've been faced with in this past year, as we've all together faced the COVID-19 pandemic. So I want to talk a little bit first about, and I think this is important to understand what equity and the pandemic and vaccination have anything to do with each other. It's important for us to first understand how health happens from a public health standpoint. So one of the ways that we describe this is thinking about a tree here, and hopefully you all can see this. If you think about health outcomes, so I did see some discussion in the chat about maybe some chronic conditions that people may have, or somebody that you love has, and you're thinking about vaccination. So we would think about this tree, and we would think up in the branches and leaves of this tree being things like, conditions that we're all familiar with, like diabetes or heart disease, or certain, other chronic conditions. Maybe you have asthma, etc. So that's where we see those, and oftentimes that's how we think about health. In terms of the outcome. But it's important for us to understand how those outcomes come to be. And so for us, we taking this metaphor of the tree here, really have to get into the roots to think about what is actually driving those health outcomes. And a lot of times we might think about health as being around the personal choices that you and I are making every day about maybe what our diet is, or whether or not we're getting enough exercise, or if we maybe if we use tobacco, right? And certainly those things play a part, but really when we think about these root causes, there's actually a lot of factors, social and economic factors, that really go into actually the choices that you are making about your health. So there's actually really big factors happening within our community and in our society that actually drive what kind of choices you might be making about your own diet. So let's say there are things like our overall food system, right? So there are people in our community who have really very different opportunities and access to good, nutritious food for them, right? Or maybe you're not making it to the doctor or the other healthcare provider when you need to. And some of that might be because you don't have adequate transportation. And public transportation, as much as, we appreciate our partners with TARC, who, run the buses in our system, in our city. Not everybody's doctor's office might be easily accessible on the TARC route, or it might not be physically possible for you to use TARC effectively in order to get there. Obviously, other really big factors, you all are part of our health and human services system. And so those, how people interact with those systems certainly are in the roots of this tree. And you all are providing education for young people in our community. You're partnering in order to do that. All of these systems together are these root causes, and they actually shape the conditions in which health happens, and they either can create good boost for health, or they might be creating certain barriers for people when it comes to being able to access good health. And then the final component here is we want to say we actually look even deeper into the soil that the tree is planted in. And this is where we see systems of power. So I know that you all at Maryhurst have done work over the years to kind of boost up how you're looking at things like diversity, or how even more explicitly, how do you address systemic racism and institutional racism, right? That's a part of your emerging work. And so this is where we would, in the soil, we would see things like racism and sexism and other isms that shape actually the conditions of the root, right? So it's first really important, again, to just understand how health happens. All of those factors beyond just the individual really are shaping how health happens in our community. And for us, from a public health standpoint, having to think about what that means for the 775,000 people that live in this community. So what does that result in? Unfortunately, what that results in our community is a significant difference in life expectancy in our community. So if you're looking at this map here, some of the areas in the darkest green, or the most saturated green, are going to be areas where people in our community do see the longest life expectancy within our community. That's more towards the eastern part of our county. And as you move across our county and moving towards the west, and seeing in West Louisville here represented on the lower end of life expectancy. And this isn't just happened by chance, right? Again, all of it has to do with some of those factors we were just talking about, right? How people experience things like education or income and wealth level, right? Like, what does your job pay you? What's your opportunity for certain types of employment? All of these factors really shape the conditions that people experience over the whole lifespan, right? From birth until death. And because of the inequities that we have in our community about how people experience those conditions, we end up with really different results. I want to be clear here, because I know that you all are trying to think critically about what this means, like what equity means for your organization, what it means for the young people that you're working with. Lots of people love these maps, and it's one way that we show what's going on in our community. And the reality is that this map represents real lives within our community. So when we say that there's a lower life expectancy, that means that there are people in our community, because of the conditions that we collectively have created, right? There are people within our community who are having shortened lives. That means that they have less opportunity to spend with maybe family, with your grandchildren. They have less opportunity to maybe have certain social benefits, or be able to pass on those benefits to their children, et cetera. There's real people who are represented behind all of these numbers. And I know that it also includes you all as staff at Maryhurst, but then also the families of the young people that you're working with. So I want to always point that out, that data is really important, and data represents real lives and real consequences within our community. So again, this is kind of another way to think about it here. And again, if you're looking at this map, I'll say all of this is available in our Health Equity Report, which you can find at healthequityreport.com. You can find this report and 2 previous reports. I'll say that our staff are currently working, even during this pandemic, our staff are working to create the next Health Equity Report, which we hope to have out later this year. And we know that, what we will have to say in that report will certainly be shaped by what has been experienced over this past year. So again, if you're looking at all-cause mortality here, we see that, you know, in the western part of our community, in the period that we looked at here, we're just seeing more deaths, right? And again, what that means for communities when you see excess deaths within your own community, and the impact that has at the family level, but then also at the community level is real. And again, these things kind of build upon each other. So I do want to think of a little bit. Okay, so we've talked a little bit about what is health and health equity, like what's the state of that in our community. We see those real differences across our community, but then let's talk about what does COVID-19 look like within our community here right now. So, you know, this is our report from this week, where we still have, right, again, over 71,000 confirmed cases. And really, you know, I think from many of our perspectives, the death toll at this point now, over 850 people within our community having died from COVID-19. I know that there may be some of you here who are participating in this call who know somebody represented in that number, or you know somebody who is very sick in one of these confirmed cases. The toll is massive on our community, and I think we have to recognize that. I know that you all are trying to navigate that as an organization, just as we're trying to navigate that as an organization, but a recognition that the toll is so great in our community and across our country and the world. And we are still very much, even as we're talking about vaccination, we are still very much in a situation where we have a lot of community spread. We hope that that is dwindling. We think we see some of that evidence as we look at here in the center of the page, cases per 100,000, right? That number being 41. We have certainly not too far in the past, long ago, seen that number be, you know, more like 76 or 78. So we're happy that that number is dwindling, but it still puts us in a critical kind of spread within our community. So we want to make sure that that you all know that even though we're talking about vaccination and the possibilities of that upcoming, that it's still really important to make sure that you're prioritizing getting tested and understanding if you're experiencing symptoms. That testing component is really important because it helps us to understand what the spread looks like in our community, in this community here. And we know that probably people are, just like you're really fatigued with the pandemic, you're probably fatigued with testing. But it's really important that you continue to do that because it helps us understand where we are as we continue to navigate COVID-19 in our community. I'm glad that Dr. Cooke referenced what some of the vaccine priority groups look like. And I see that I think somebody put in the chat, like maybe where you can find this information. If not, I'll do that once we begin our discussion. But you're able to find on the city's website here what the phases are for this community and who all is included in that. I will say that I know that a lot of times we get very specific questions about is this specific person eligible, right? I want you to know that it's not necessarily possible to list every single type of scenario on this one graphic. So it's important to be able to reach out to us, and I have some contact information at the end of these slides for you to be able to do that here locally. But again, especially as we move into, you'll see in phase 1C, we start to talk about people who have certain chronic health conditions, and it is just not possible to list every possible chronic health condition that might be included in that. So that's where reaching out to your physician or reaching out to us at the hotline number at the end is going to be really important, because we just can't have an exhaustive list here. So this is important, right? Phase 1, healthcare workers, long-term care facilities, and then phase 1B, which we're in, thinking about what's been prioritized by the state, first responders, but then also K through 12 educators, and then individuals who are age 70 and older. So that's really important to think about as we talk about these next few slides. So I want to talk about, we published this data this week, and it'll be updated every week for the public to be able to see. So what's important to, when you're looking at this particular data here, is to understand that we are representing on this slide actual doses of vaccines who are administered to Jefferson County residents. The reality is because, as may be the case for some of you, you may not necessarily live within Jefferson County, but perhaps you work here, and so you're included in some of the vaccine distribution that's already happened. But for this particular slide, we're actually looking at only representing the numbers of people who have received at least one dose of the vaccine. Maybe some of them have completed, but they are actually Jefferson County residents. So you'll need to, as you navigate some of the data, you'll see some of that difference there, and that's what the difference is. So as of earlier this week, almost 101,000 doses of vaccine being administered. Our Jefferson County residents who had received at least one dose of the vaccine. Again, we just talked about that the doses that are the types that are available right now is 2 doses that you need in order to complete the series, was almost at 80,000 at this point at the end of the week. We're certainly above that. And then total Jefferson County residents who had completed the COVID-19 vaccine series. That means that people who have received both doses was over the 21,000 mark. And when we're thinking about equity, one of the things we want to look at is what's the breakdown of how people are receiving this across racial and ethnic groups. And we'll highlight here, probably because they represent the 2 largest groups within our community. We could see that earlier this week, where white people represent about 81% of the population in Louisville, Jefferson County. 71% of our total population. Of those who had been vaccinated, they represent about 81%, right? So a little bit higher proportion of those who had been vaccinated compared to what that population represents for the total. We'll talk a little bit in a second about why we think some of that is. And then we look at our Black population, who represents about 22% of our Louisville, Jefferson County population. But when we look at those who have been vaccinated so far, representing only about 11%, okay? So then some other pieces of data that you may be interested in, or maybe not, what agencies have delivered this, and then also by age group here at the end. Of course, we would see those older adults we would think should be at the highest end because they're being prioritized and also share some of the greatest burden of mortality related to COVID-19. So let's think a little bit about some of the inequities in COVID-19, and then we'll talk about what some of the challenges are in vaccine distribution. So COVID-19 has exacerbated inequities which already existed. So again, we talked about what was the health status, the overall health status of our community already, and we recognize that people of color already shared a greater burden of certain chronic health conditions like diabetes and heart disease and cancer, and that happens because of the structure of our society, systemic and institutional racism, and the history of that, and how that's led to lack of fair and just opportunities to be healthy. So we take that as our starting place, and then we've added this COVID-19 virus. And it has created then for us really a situation, again, that kind of magnified the inequities that already existed. And when we look at like what that really looks like in our society, we could say that, okay, people of color make up a disproportionate share of essential workers. So what does that mean? That means that during this past year, in order to maintain a livelihood, people of color were more likely to have to continue to work out in public spaces where they have to interact with the public, have more vulnerability to exposure in that way. Also less likely to have access to paid sick leave, right? There are millions and millions of people in this country who work and may work a lot, but don't even have access to 1 hour of paid sick leave. So if you're gonna put food on your table, or if you are going to continue to have a roof over your head, you have to work, because there's not an opportunity like many of us enjoy, myself included. I enjoy the opportunity. Hey, if I'm sick today, I can pay up the sick day, and I'm still gonna not lose any income. But there are millions of people across the country who do not have that. And disproportionately, that group is made up of people of color. So you end up with significant inequities, even amongst an inequitable condition like not having access to paid time off. And then we already talked about, right, because of systemic race and the long history of that, again, detailed quite a bit in our health equity report. We end up with people who have pre-existing conditions, and then that creates a situation where you're also then, right, now that we have this virus, which is dangerous and deadly, putting you in a place where, because of your health status, you're less likely to have the best outcome for having when you have COVID-19. So collectively, this leads us to a situation where then we have inequities to begin with. We introduce COVID-19. COVID-19 makes those worse. And then we have to look at, now we're at a situation where we're going to think about vaccination. So what are some of the equity changes in vaccination? In fact, some of this, and we're thinking about to that slide about 1A and 1B, so who's actually eligible within vaccine distribution phases, right? So the first group, the big group there in 1A was healthcare workers. Well, some research indicates that research was done to look at about 30 healthcare professions, right? And it turns out that in about 23 of those 30 healthcare professions, white people have higher rates of proportion within those professions, right? And there's different reasons that might happen, right? You have to be able to access certain education routes and pay for that, right? Certifications, et cetera. All of these things are time consuming and resource consuming. And so and also history of practices where people were not allowed to practice, right? Policies where people were not allowed to practice, right? Or only practice with certain groups, right? So now at this point, people of color, specifically Black people, representing smaller proportions of healthcare workforce. But then we're saying, hey, healthcare workers, you're first in line. So we see an overrepresentation of white people in that group. You'll see the same here in Kentucky in phase 1B. We are prioritizing public school educators, or educators period, right? K through 12 educators. There's a long history. What has happened in this country is that there was a period of time when our schools were segregated, where there were actually more Black teachers. And then as schools were desegregated, specifically white families said, I actually don't want Black teachers teaching my children. And so we actually lost a lot of Black teachers during that history of our country. And so now something today like 82% of our public school educators are white, 82%. So really overrepresentation in that group. And here in Kentucky, we said K through 12, you're next in line. And so we see then, again, an overrepresentation of actually who's eligible within the vaccine distribution phases. What we've done here locally, though, and this is if we're going to prioritize K through 12, it's really important that we've also included bus drivers and all the other people, just like Dr. Cooke was talking about, all the other people that make the hospital run. Then we've also included all the other people who make schools run, right? Some other equity challenges that we're facing is, resource inequities create barriers to the vaccine, even as people become eligible for vaccination. So what does that mean? So maybe now, if you're 70 and older, you're eligible for vaccination, but you might not have access to the internet or be able to use it effectively in order to sign up for an appointment. In our community, there are certainly people who don't have adequate access to transportation. And like we talked about before, maybe you have access to TARC, but you don't have the type of access you need in order to get in a car and go at a specific time to show up for your appointment. And you don't have access to information. Again, Dr. Cooke kind of hit on this. You have access to reliable information about whether or not you're eligible right now. How do you sign up? All of these different components that go into helping you make sure that you get an appointment and get there on time. And again, that access to a trusted healthcare provider. We know that a lot of people, in order to navigate some hesitancy that they might have, starting at your healthcare provider is a really important place to start. But if you don't have that trusted healthcare provider, it can be, again, just another barrier in order to getting people ready and willing and positioned in order to get vaccinated. And finally, I won't harp on this too much. I know that Dr. Cooke really covered it quite well, but distrust of the healthcare and medical field, and rightfully so, and also of government institutions. So all of those together are kind of leading us to some equity challenges for communities, Black and Brown communities, which have been especially hit during this time, leading us to a place of whether or not we can, how we build up trust or how we navigate within communities to find the right people who can deliver the message of vaccination is one of the tools that we want to use in order to fight the pandemic at this time. So these are some of the equity challenges that we're facing, and they are certainly numerous, and they will become, I think, we foresee them becoming greater as more and more people become eligible. I think as that group grows, then we will be faced with more and more dynamics of what are some of the barriers that people are facing in order to get themselves positioned to be vaccinated if it's something that they're choosing. And finally, I'll just leave this up. I know we're going to take a lot of questions, and I'm happy to do that and engage with some question and answer, but I want to leave this up here for time. So if you're having questions about, hey, when is it going to be my turn, or I have this specific health condition, or, et cetera, there are so many questions out there about vaccination. And also, you might still be having questions about COVID-19. We want to point you in the direction of this hotline. There's a lot of public health professionals there who are ready to answer your call and be able to provide you with some accurate information about what's happening here locally.
Thank you so much for that, T. That was really just awesome. And so I appreciate you going through that. And I do have a few questions. Any of our participants, if this has sparked a question for you, I encourage you at this point to put your questions in the chat, but we'll go ahead and get started. We talked some, and we also heard talk about vaccine skepticism. Can you talk about how the Center for Health Equity is working to approach vaccine skepticism in our local community?
Yeah, absolutely. This is a part of like where I was talking earlier about, we see ourselves as, as strategists. We have both a vaccine task force that we head up, but that's in partnership with our healthcare partners and others across the community, as well as a specific task force that is really that's solely dedicated to how we communicate about the vaccine within our community. And really so much credit has to be given to healthcare partners and as well as other kind of partners like yourselves who are taking the opportunity to bring this message in whatever way possible to the people in the communities that they interact with. So some of the things that we are doing is partnering with Black and Brown organizations because we realized, as Dr. Cooke said, and I think he said it well, that it is not the responsibility of our community residents to build trust with us, right? So we, as your local government, have to recognize the places where there are barriers to trust and why that is. And so we are working closely with people who have those trusted relationships within our community, who are eager to bring the messages about the vaccine, what it is, and when you will be eligible and all of that, and why people are choosing that. Just today out at our LouVax site at Broadbent, I know we had some from our international community who were being vaccinated there. And these are folks who are stepping up to recognize, we want to make sure that all kinds of people within our community are able to see people who share their culture, who look like them, who are able to be vaccinated. So we've done some of that here locally with the Urban League. We're communicating with churches in order to be able to do all of that. So it really is dependent. Like, we are working heavily with our community partners in order to get that message out because we know that they have those trusted relationships and people are looking to them first for accurate information.
Yes, that's great. That's great. Thank you, T. Another question that I have here, how do you see public policy influencing health equity and health outcomes? And how do you and the center work in that particular space?
Yeah, so, one of these, it has, public policy has everything to do with health equity. We understand that the ways in which we can shape health, again, our role is to look at, while we are concerned about your individual health, we are certainly looking at our whole population, and public policy is an avenue by which we can certainly impact that. So if you think about a little bit about what I was discussing earlier about paid sick leave, we are in desperate need at the local, state, and federal level for policies that require the access to paid sick leave. And that's not just important for us during this pandemic, but it is important for us to have a healthy community in the future. There will be a time that we are past this pandemic. I don't know when that's going to be, but there will be a time when that's the case. But listen, every year people have the flu. It feels like forever ago, but it really wasn't that long ago. We're here locally. We had hepatitis A outbreak. We want, from a public health perspective, we want people who are sick and not feeling well to be able to stay at home, to keep themselves healthy so they can take care of themselves, but also it does a great service to be able to help prevent the spread of all types of disease within our community if people can stay home when they're not feeling well, right? So you know, all of us have experienced, you know, somebody were like, they probably should stay home. I mean, maybe they got the flu or something, right? No, right? Like, none of us wants to work alongside somebody that has the flu, right? But for a lot of people in this country and in our community, don't really have the option to stay home, not if they're going to make rent and not if they're going to put food on their table. It's either go to work, and in some cases you might be fired if you miss your shift, right? So it's maybe like lose your job. So it has everything to do with public health. And our role is to be able to speak to that with our partners, to our legislators. We have different tools that we use for that, like health impact assessments and things like that. Then I get a little bit into the weeds of public health practice, but we certainly work with our Metro Council when they approach us about different policies that might be good for public health.
Thank you for that. Can you hear? Okay. Got a little error message on my screen. I apologize for that. In the interest of time, there's one key question here that I want to have you touch on, and that is, what are some ways that people in our community can support the work that the Center for Health Equity is doing? And where I think it was posted in short order there in our chat, but I just would like for you to reinforce where we can go to learn more about your work and how we can support the work that you're doing.
Oh, well, absolutely. And again, you can find us at healthequityreport.com. And I see that the link also to our website has been posted in the chat. So we welcome any opportunity to connect with you. And there's forms there so that you can fill out on our website and connect with us. I think what is really important, you know, we do our work kind of inside of government. But I would encourage each of you, I think a real tangible thing is when you see policies that are being discussed here at the local level, understand that you are somebody who is represented by a Metro Council member, and you have every right, and I would say a good duty in order to reach out to your council members and say, hey, you know what? I've been thinking about it. I heard about this issue being discussed, and I think you should support this, right? Like, or maybe this is something that I think is going to be bad for our public health, and you shouldn't support this, right? I think that is a real tangible thing. I am really a proponent of people understanding that the government, your local government, is yours, right? And so it really does mean a lot when you reach out to us and say, hey, here's an issue that I'm concerned about. And we're certainly within the Center for Health Equity and your local health department open for any and all ideas that you have about how we might improve the public's health and advance equity in our community.
See, this has just been an awesome presentation. I know that I personally learned a lot. And I appreciated the way that you connected the dots on some facts that we know are out there to explain outcomes in such a clear way. I just want to thank you on behalf of our organization, our community, for the work that you're doing. And at this point, just to close us out, I'd like to hand it over to Paula.
All right, thank you, T, and thank you, Adisha, and we certainly appreciate everybody who joined us today. This will be this is recorded, so we will be offering this out also so it can be shared with those who couldn't join us today. It's such a critical conversation, and certainly the health disparities and inequities has been illuminated by the pandemic, but it's a conversation that we have to continue to have, and something that it's critical that we continue to work with our community and our community leaders on. So thank you all. And again, T, for this opportunity. And just thank you for sharing this time with us, those of you who joined in. We appreciate it. And we'll be sending out, again, a recorded copy of this as well. Thank you. Have a good